Hello, I'm Dr. Yvette Rubidoux, and I'm the Vice President for Research and the Director of the Policy Research Center at the National Congress of American Indians. Welcome to today's webinar series. Today, we will focus on Introduction to an Interactive Opioid Mapping Tool. We're so glad that you joined us today, and we encourage you to watch for our webinar series. We try to hold them monthly, and they focus on how data informs policy and feature a variety of topics and various guest speakers from time to time. I encourage you to join our listserv for announcements by emailing research@ncai.org. We will also announce our webinars on Twitter and on our website. If you missed any of our webinars, the recordings are usually available on our NCAI YouTube page or on our website, www.ncai.org/PRC under Events and Webinars. Here's an overview of today's agenda. I just provided a welcome. And then our speaker today is Michael Meat, co-director of the NORC Walsh Center for Rural Health Analysis. And once our speaker is done with the presentation, we will reserve time for questions at the end. And we'll ask that you write your questions in the question pane. But before we get started, I'm going to review a few housekeeping items and let you know how you can participate in today's web event. So this is a depiction of the GoToWebinar Attendee Interface. It's made up of two parts, the viewer window on the left, which displays the presentation, and the control panel on the right. I'll quickly navigate how to use the control panel so you can readily participate in today's web event. So by clicking on the orange arrow, you can open and close the control panel. And then it's here where you will find the information about your audio connection. We recommend dialing in via phone rather than the computer, as it tends to limit feedback. To dial in, you will find the number and access code here along with your unique audio PIN. And as you can see, all attendees are currently muted and in listen-only mode. And at the end of the presentation, we'll open for questions and answers, or Q&A. And at that time, please submit your questions via writing them in the questions pane. And as a reminder, today's webinar is being recorded. After the event, you'll receive an email with a link to a short evaluation, and the recording will be available soon on our NCAI YouTube page and our PRC website in a couple of days. So now, we'll start the presentation. And I'd like to welcome Michael Meat to provide the presentation today.
All right, thank you so much. So I am really happy to be discussing this topic with you. This is a project that we have developed. It's something that's very near and dear to us. And what I want to do is I want to walk you through our opioid mapping tool, tell you some of its functionalities, and I want to then show you ways that you can access data that's relevant for tribal communities, and have a bit of a discussion with you on some of the data limitations, particularly for tribal communities. If you can go on to the next slide. Just to get us started, to let you know who we are. So we are from the Walsh Center for Rural Health Analysis. We are a nonprofit research organization headquartered in the Washington, D.C. area. We have been around since 1996, and we do a lot of work for mostly federal agencies, but also for various foundations as well. And within that, we do a fair amount of work with tribal communities as part of our larger rural portfolio. If you go on to the next slide. So the specific project that I want to talk to you about today is our opioid misuse community assessment tool. This is a project that was developed for the United States Department of Agriculture. Usually when I mention that, people are surprised that the Department of Agriculture is funding this. And really the reason for that is that USDA is the lead federal agency for rural opioid overdose. So that's really the connection, is that rural angle. And the tool itself was really developed with that rural lens in mind. If you go on to the next slide. So when you go onto the tool, this is the view of the map that is produced nationally. So the tool itself can be found at opioidmisusetool.norc.org. And what you see here is a heat map of overdose mortality nationally. I will show you some zoom in so that you can get a more granular view of what this looks like. But essentially what we have done here is we have mapped overdose mortality data. This is a view of all-cause overdose mortality, and we've aggregated it across 5-year time frames so that we can report data for the largest number of communities possible. CDC guidelines require that there be at least 8 cases in order to report data. So you see in that middle part of the country, which is a part of the country where a lot of tribal reservations are, you notice that that area is grayed out, and that is because there are fewer than 8 cases even aggregated across 5-year timeframes. That is one of those data issues that I do want to discuss with you. What you will notice here, and again, I'll provide some more focused zoom in so that you can see this, but you'll notice even from this view that the areas with the highest burden of overdose mortality are the Northeast, Appalachia, the Southwest, and Oklahoma. There are pockets elsewhere as well, but in aggregate, those are the areas of the country that appear to have the highest rates. If you go on to the next slide, this is just the data that are behind the tool. So I mentioned this already. This is CDC mortality data. We have used all-cause mortality for a reason, and that's because that is a more accurate data set. It is considered a better data set than opioid overdose data. Essentially, when the death records are completed, the primary code is overdose, and the person who is recording the death record then has to go into subcodes to be able to report opioids or other substances, and the data get less reliable and are just simply less reported as you get into subcodes. So we use all-cause mortality data. And then in a bit, I'll also show you some overlays that we've included. And this is socioeconomic and demographic data, and that comes from the US Census Bureau and the Bureau of Labor Statistics. If you go on to the next slide. So the tool allows you to view data at both the state and county levels. This is the state level view, and we've included 2 5-year time periods. Within the tool, you can switch those 5-year time periods so that you can see trends over time. And you'll notice here that in general, states have gotten darker between the 2 5-year time periods. You see that again in those regions that I described, the Southwest, Appalachia, and the Northeast. If you go on to the next slide, this is where we start to get into that county data. This is the view in the Northeast. And again, you can see that rapid increase across those 2 5-year timeframes, really throughout the Northeastern states, but particularly in New Hampshire, Pennsylvania, and Ohio. If you go on to the next slide, this is what it looks like in Appalachia. And again, you see Central Appalachia as an area where those rates have increased. The other notable increase is in the Ohio Valley here, the area in Southwest Ohio that is kind of the Cincinnati, Dayton corridor and surrounding it. That's the urban area of the country that has the highest increases in overdose mortality currently as well. And then if you go to the next slide. So this is a view of the upper Midwest, and I show this really for a couple reasons. One, in general, the upper Midwest has lower rates, but you still see that these rates have increased between the 2 5-year timeframes. But I also want to point out to you the 2 darkest counties. You'll see one in Minnesota and one in Wisconsin. Those are both tribal communities, so we do see very often that areas that have these very high rates are in tribal communities. You go on to the next slide. You see this as well in the Southwest. Particularly notable here, you'll see a lot of counties in New Mexico and Colorado, but I think Oklahoma is also particularly notable here. And Oklahoma as a state is a state that has seen this rapid increase and also has one of the largest tribal communities in the country. If you go on to the next slide. So this is that socio-demographic and economic data that I had mentioned. And essentially with this data, we have created overlays, and we have overlays for race and ethnicity, for age, for educational attainment, disability status, median household income, poverty rates, unemployment rates, and accident-prone employment. And I'll show you a couple of examples. We are also continuing to build this tool out. We continue to add new functionalities and new data for USDA each year, and we're in the process of adding some additional data sets here as well. Some of those will include overlays of highway systems, of broadband access, links to provider information, things like that. If you go on to the next slide. So this is where we start to get into some of the data that we have on Native American populations. So this is a view of race and ethnicity, and the bubbles that you see here, the larger bubbles are the counties that have larger Native American populations. You see those two counties that I mentioned in Wisconsin and Minnesota, but you also see some other notable counties where there are large tribal populations and higher rates of overdose mortality, for example, in Idaho and Montana. What you also see here is one of the things that concerns us, which is that we are not able to report data for many of the communities in the Dakotas and across Montana where there are large Native American populations. So there are really two primary possible reasons for this. One is that the rates are very, very low, which would be a good thing. The other is that the reporting is not very good, which is one of our concerns. And I would love to have some of that discussion with you. The other factor here is that these are low population areas, so it's simply harder to get beyond those CDC thresholds in lower population areas. But we do have concerns based on at least anecdotal information where we hear about overdoses that are not reported in tribal communities and in rural communities in general for a variety of reasons, not the least of which is stigma. And again, I'd love to have that conversation with you. If you go on to the next slide. This is also a slide that shows race ethnicity. This is Native American populations in the Southwest. Again, you see this trend where some of the counties that do have high rates in Colorado and New Mexico do have large Native American populations. And then you see that this very high rate that we observe across the state of Oklahoma is concentrated in those areas where there are large Native American populations as well. And if you go to the next slide. So I also just wanted to quickly show you some of the other overlays. So this is an overlay of poverty. So the higher rate of poverty, the larger the pink bubble. What you see here, what you will notice if you look at this data across the country, is that there are a lot of places where there are high levels of poverty, but not high overdose rates. But most areas that have high overdose rates also have high rates of poverty. So there is an association there. If you go on to the next slide. This is a view of unemployment. Again, kind of similar trends where there are places where there are high rates of unemployment that don't have overdose issues, but generally areas that have higher rates of overdose mortality do see high rates of unemployment as well. And if you go on to the next slide, So this is another function within the tool that I want to show you, and we'll have a couple of zooms here as well. But you'll see if you look in the upper right-hand side here, you see that we have map overlays. We are adding overlays here as well. This is where we'll have overlays, for example, of the highway system. But you'll see that we do currently have an overlay of tribal reservations, and those are the outlines in those yellow outlines around the country. If you go to the next slide. So this takes us back up to the upper Midwest. And again, this is where you can also see those counties that I showed you in Wisconsin and Minnesota, and you see the outline of the reservations. But you will also see in other areas where there are higher rates of overdose mortality on reservation lands. But again, we see that the data are suppressed for many of these counties. And again, that's something that I'd like to talk to you about. If you go on to the next slide. This is the same overlay of tribal reservations, and this is the view in the southwestern states. And if you go to the next slide. So this is back to the state view, and the other thing I want to show you, and this is something that I really personally like about the tool, it's something that we get a lot of positive feedback about. So when you click on your state, if you go to the next slide, you can pull up a fact sheet for your state. So this is the fact sheet for Oklahoma, and you can compare the overdose mortality rate in your state to that of the nation. You can get the total number of deaths across the 5-year time frame. You'll note that there is a toggle here where you can compare change over time. And you get all of the socioeconomic and demographic data that we have in the overlays all on one sheet. And this can be printed or emailed. And our intent was so that this could be sent to policymakers, to various stakeholders, to help them think about planning and response related to opioids. And again, here you'll notice in Oklahoma, for example, that 7% of the population is Native American as compared to less than 1% for the rest of the nation. And if you go to the next slide, you'll see that you have the same functionality at the county level. So when you scroll over your state or over your county, you'll see the rate for the county. When you click this View Details button, it brings up the next slide, which is that same type of 8.5 by 11 sheet. It prints out as a fact sheet. And again, you can send this directly to community stakeholders and planners. And you can compare your county to your state to the nation. This is one of those counties where there is a reservation. You can see that the rate here is 90 per 100,000. That's about 4 times higher than the rest of the nation, about 5 times higher than the rest of the state. And again, you get all of that demographic and socioeconomic information as well. I think I have one more example on the next slide from New Mexico. This is Rio Arriba County, New Mexico. And again, you see the rate there is 136 per 100,000, which is one of the highest rates in the country. And you can compare that again to your state and to the nation. And then if you go to the next slide, this is where I just wanted to let you know, I mentioned some of this already, where we are going with this next. I mentioned some of the additional overlays. We are also creating an integrated resource directory. This is something we're also very excited about, where when you access this data, we're also going to link people to funding resources and opportunities, as well as best practice information so that they can really help to inform that planning at the community level. And then the other piece is we're adding a prosperity index. And this is something that hopefully will be completed in the next couple of months. And this is a 16-indicator index that looks at measures of both risk and resilience at the community level. And when we talk about risk and resilience, we're thinking about risk and resilience related to both economic issues as well as social and health issues. And And what we've done is we've created this 16 indicator index so that we can create a map of the United States where we can show the different levels of risk and resilience by individual indicator as well. And we're going to create similar county level fact sheets where you can get that underlying information so that you can see where your county scores higher or lower in an effort to help communities, again, plan for strategies to both decrease risk and increase resilience at the community level. So that's something we're also very excited about. And in doing so, we're hoping that we can start to get at some of these underlying community factors that appear to predispose communities towards various social ills, including opioid overdose. If you go on to the next slide, the last thing I wanted to do is I also wanted to let you know about some of the other projects that we're working on to help inform communities in their planning efforts. So for the Federal Office of Rural Health Policy, we have a project. It's a series of evidence-based toolkits. These are housed on the Rural Health Information Hub. I'll share the website in a little bit with you. But basically, I think we're up to 23 toolkits now on a variety of topics, everything you can imagine from oral health to mental health to obesity to the one that is shown here, which is the prevention and treatment of substance use. And if you go on to the next slide, each of the toolkits is built around these 7 modules. We introduce the topic. We talk about different evidence-based program models. We provide a clearinghouse of best practices and information, considerations for implementation, considerations for evaluation, which is really important. We want people to be evaluating programs so that we can continue to grow the rural evidence base, and then strategies for sustainability and dissemination. In this particular toolkit, we have identified 6 evidence-based models for substance use treatment, and these are medication-assisted treatment, behavioral therapy, harm reduction, care delivery, peer-based support, and prevention. And when you click on these, you will find specific recommendations for implementing rural programs and best practices and program models with contact information to help stimulate peer learning. So this is something that we really, again, we encourage communities to use these, and these are available free of charge through the Rural Health Information Hub. If you go on to the next slide, this is what the page looks like, where all of the toolkits are housed. You can see the links to the individual toolkits here, and this is the website where you can find this. It's ruralhealthinfo.org/toolkits. If you are not familiar with the Rural Health Information Hub in general, it is the federal government's one-stop shop for rural health information. It is a fantastic resource. Our toolkits are housed here, of course, but there is a wealth of other rural health information as well, so I encourage you to visit their website in general. And if you go to the next slide, these are the different topics that I would love to discuss with you. So I mentioned this already, but our concern in terms of looking at overdose mortality in tribal lands is often a concern around data quality. This is a broader rural concern, but we certainly see it in tribal communities as well. And the questions come down to essentially to reporting issues. So what we see is that very often in rural communities, because of social relationships, close-knit communities, very often there is underreporting related to stigma or simply trying to protect families. And very often the people who are completing death records often don't have the same level of training in rural communities. So that becomes an issue as well, just in terms of data quality and consistency. Other things that I wanted to throw out for discussion. So clearly the federal focus right now has been on opioids. That is driving the concern and the funding. But more and more, we are hearing about other substances not the least of which is methamphetamine. That becomes challenging for us as we're looking at overdose mortality because, I mean, this is kind of a crass way to say it, but there's no other way to say it. The reason that opioid data tends to be better than other substances is because opioids are more deadly. We're looking at overdose mortality and substances of abuse that are scourges within communities but don't kill people are simply harder to track. And that becomes a challenge for us as well. So again, anecdotally, we hear a lot about methamphetamine as well as other substances, but those tend to not be as deadly, so that we just don't have as good a data. So I would love input on that as well. And then as we continue to build out our resource information, we're always looking for information on funding and best practices. If you have thoughts or resources that we can be integrating into our resource directory, we would love that information as well. And if you go to the next slide, this is how you can find us. This is the link to our overdose misuse community assessment tool, the tool I just showed you. And with that, I am happy to take any comments or questions that anyone may have.
Great. Thank you so much for a great presentation on what looks like a really interesting tool to use to look at overdose deaths and all of those kinds of things. So now what we're going to do is take time to ask some questions. And so for everybody on the phone, you are welcome to write your questions in the question pane on the right, and I will go through those questions and ask them of our speaker. So, all right, let's see. We do have quite a few questions. All right. Someone asked if this webinar is recorded and available for future viewing, and yes, it will be. We'll have it up on our website and send it out, the link out on Twitter, probably within a week or two. And so we encourage you, if you know anybody who couldn't make it to the webinar today, please have them view the webinar on our website. And another question, will there be a copy of the presentation be made available to the participants? We have, as I said, the webinar will be available, and then the slides are included in the webinar as well. So next question is, this looks like a good resource given the data limitations, but one data point can be added easily. Instead of using American Indian Alaska Native alone, use American Indian Alaska Native alone and in combination. So based on the census data, but do you have a comment about that related to how the census data is used, or how if the mortality data has that kind of coding, American Indian Alaskan Native alone or in combination?
Yeah, we will have to go back and look at that data set. It's a good thought. We need to go back and confirm as to whether multiple race data is included, and we can do that. That's good feedback.
About that is the mortality rates or vital statistics rates from CDC, right?
Yeah, that's correct.
And then the overlays that you're using are the census data, correct?
Yeah, that's correct too. So the overlays are census data, with one exception. There is also data on injury-prone employment. So manufacturing, mining, timber, other types of high injury jobs. That data comes from the Bureau of Labor Statistics.
Oh, okay, great. Thank you. Another question or comment It is great to see the expertise of centers like NORC adding American Indian Alaska Native data to their models and working through the specific differences that need to be considered. And then the next question is, some studies say that the misidentification of American Indian and Alaska Natives on death certificates can cause mortality rates to be about a third lower. The underreporting is around 30%. Have you factored in any adjustments for underreporting of American Indian Alaska Native race on death certificates in this tool?
So we have not, and so this is a really important point. So there are really two issues. One is exactly what that individual just noted, which is that that indicating the American Indian Alaska Native status of an individual on the death record is underreported. But in addition to that, overdose mortality itself is underreported, and that's estimated to be underreported by about 30 or 35% in itself. So there are two levels of underreporting here, which are really, really important. The problem is that neither of those are underreported consistently. So some places, some coroners or attending physicians or whoever is filling out this death certificate, some do a better job than others. So it's something that everyone needs to be aware of. In aggregate, we know about the general level of underreporting, but by region, by community, it varies widely, and that's a problem.
Okay, great. Thank you. Yeah, that's a particular problem that people try to adjust for when they look at mortality statistics with American Indians and Alaska Natives. And it's, I guess I didn't know that the overdose data also has underreporting. So that maybe that explains some of the gray areas on the map where there's no data available.
It very well could. So I mentioned it during the presentation, but those gray areas, you probably have a confluence of potential things happening. One is that they're low population areas. So getting above a threshold in a low population area is just simply harder. Two, the rates could be lower. There could be an actual lower rate there. And then three, there could be other factors like misclassification, misidentification, underreporting. All of those things come together. But yeah, we do have about a quarter of the counties in the nation where we are not able to report data, and those tend to be concentrated in the middle part of the country, the lowest population centers in the country.
Great, thank you. The next question is, what methods are you or others using to either increase reporting of Native mortality or confirm that the total is low in areas where there's not enough data to report?
So we are not in a position to influence that directly, but we have made recommendations back to CDC and others about the need to improve reporting. And that's frankly overstating our role. It's not something they didn't already know. They understand the challenges, and I think there are initiatives in place to try to improve overdose reporting overall, and I think in particular within Native communities, trying to improve the accuracy of that reporting. So there is an understanding that this is a problem, and hopefully some of those efforts are underway to try to address it.
That's great to hear. I mean, you hear about all this new federal funding. I hope some of it's going into improving the data. That's for sure. The other thing is that, hopefully the tribes are going to talk with state officials and with the people who actually fill out the death certificates, which are coroners or funeral home directors or doctors, and trying to encourage them to be more accurate about their race and ethnicity reporting and their diagnosis as well.
Yeah, and I think that's where tribal leadership could play a really strong role, helping people understand the importance of having accurate data in this regard, because it's hard to pull in the needed resources if you can't demonstrate the magnitude of the challenge. So really helping people appreciate that, I think, is a really strong role. I think also communicating through tribal liaisons back to federal agencies, IHS and CDC, to really help them understand the importance of working with tribes to increase the quality and consistency of that data as well is really, really important.
Great, thank you. The next question is, how often is the data updated, and is it readily available for viewing to capture current trends and statistics?
Yeah, so the data that we are using are updated annually. The most recent data that is available is 2017 data. The data tend to come out around December, and they lag by about 2 years. That in itself is a very big challenge, as you can imagine, because this is a fast-moving crisis. The nature of the epidemic changes rapidly, and probably the best example of that is the move from prescription drugs to heroin to now fentanyl, each of which has increased the mortality rates exponentially. Looking at data that's 2 years old doesn't tell you what the crisis is looking like now. So that's all really important to understand. Couple of things that are important. So CDC is working with a lot of states now to have more timely data. There's a program, it's called the ESOS program. I don't know if I'll know what the acronym is offhand, but it's Enhanced Surveillance for Opioid Overdose System, maybe. So they do have this system in place where they are reporting and cleaning and verifying the data in a much more timely manner so that they can actually have data that only lags by a quarter instead of by 2 years. And that's really important. But that's not available nationally at this time. We, each year, update our tool with the most recent data available. But again, the data that we have access to tends to lag by 2 years.
Great, thank you. That's such an important point about the availability of data, because I've heard some tribes talk about how, they're having trouble finding data available that sort of matches the circumstances in their tribes. And, one of the issues might be that it's meth, not opioids or other drugs, but the other issue is that the data is just not complete. And then also the data is often not available for small populations in rural and remote areas. What is your center doing to deal with those issues of getting good data in rural and remote areas?
So this is probably one of the biggest challenges that rural researchers have. And there are really two main strategies that you can use. One is to do what we did in our tool, which is to aggregate multiple years of data. So try to pool data across years so that you can get beyond those reporting thresholds. The other is to increase the size of the geography that you're looking at. So instead of looking at counties, look at regions or states or groupings of counties so that you can pool data really across geography. Those are really the only two strategies that you have. This gets more complex once you get into other types of data. So, for example, we tend to gravitate towards mortality data because that's a more complete data set, because like it or not, at some point, we're all going to be part of that data set. So the numbers tend to be larger. And when we're looking at leading causes of death, we can tend to get good numbers. But when we get into health behaviors and are relying on survey data, the survey sample sizes are never large enough to drill down to a very granular level. So smoking rates, obesity rates, things like that gets really, really hard. And typically we don't have good data in rural communities. So it's definitely an ongoing struggle with rural information. I know that tribal epicenters struggle with this as well in tribal communities. But at some level, the only way you can really address this is to aggregate data either by geography or across time.
Great, thank you. It is an ongoing challenge, and I appreciate your comments about that. We have another question. Is this a tool that NCAI will recommend states to use in reference to overdose data specific to tribal communities? I think I want to say that, you know, I don't think it's something that NCAI formally recommends, but we're just showing the tool to see if it's helpful to tribes and tribal organizations as they think about trying to get overdose data for tribal communities. If a tribe were to use this data in a grant application or in a presentation or publication, what kind of qualifiers would you want them to, or limitations would you like them to mention so that, you know, what are the strengths and limitations that you would have a tribe say if they use this data?
Yeah, so I think it's just important for everyone to understand exactly what you said, the strengths and limitations of the data. So the numbers that we report are 5-year aggregate numbers. One of the major caveats to that is that because overdose mortality has increased across those 5 years, and in many areas it's increased dramatically, the 5-year average is typically an underestimate of the current rate. So people need to understand that whatever number we're showing in this tool is probably lower than the current number because this is something that's on the rise. I think that's an important thing for people to explain in their grant applications. The other things are that these are age-adjusted rates looking mostly at adult populations, and again, aggregated across 5-year timeframes and limited to the most recent data available in 2017. So again, as things have continued to increase, rates are probably even higher now, even if in a 5-year aggregate. So I think all of those sorts of things are things that people need to understand and explain. We are happy to help users of this tool understand exactly what the data are telling them and what they are not telling them. So if anyone has any of those concerns or questions, we're more than happy to talk to them. I do think because this is a USDA tool and it is something that the Federal Interagency Work Group on Rural Opioids, that's run out of ONDCP, the Drug Control Policy Office, because of all of those connections, I think that in your federal grant applications, this is probably a good tool, good data to reference because it is federally supported. I will say that we would love to incorporate more relevant tribal community information and would love to work with you on doing that. So, we have some thoughts on what that might look like, but we would need the help of people who are immersed in tribal community data to really understand the nuance of that. And we would love to work with you on making this more relevant to tribal communities and possibly even working with you to help bring IHS into the mix on the types of data that could be incorporated.
Great, thank you. The next question relates to, in addition to tribal nations who have their reservation boundaries, there are a number of urban areas that have large populations of American Indians and Alaska Natives. With the Indian Health Service, they fund some of those with funding for urban Indian organizations or centers. One of the questions was, do you plan to expand the tool to include urban overdose data for states that have urban tribal communities?
So right now we have data for every county in the nation. So urban counties are included within our data set. The challenge for urban counties in general, this isn't a tribal issue, this is just a general issue for urban communities, is that because the populations are so large, you can essentially heat map down to a sub-county level, and that's something we're really interested in doing. We would like to drill that data down to census tract level so that we can look at differences within large urban areas by populations. That, I think, would have more utility for urban areas because of our current funding, which is rural funding. We don't have the resources to do that, but it is something that we are really keenly interested in doing. Beyond that, this is another conversation I would love to have with all of you, is how we could try to pull out urban Indian information, whether that is included in death certificates in a manner where we could actually do that type of reporting. The numbers may be sufficient to do that within larger urban areas. We'd have to dig into that a little bit, but I think it's a really important recommendation if it's something we could do.
Right, totally understand that. Well, certainly I hope the participants on the call, and I'll try to do that, to mention this to the Indian Health Service, since they have connections with those urban Indian health organizations, and maybe they'd be willing or interested in a partnership to try to help overlay that on the map as well.
Mm-hmm.
The next question is, if a tribe is looking for opioid overdose data versus overdose data for other types of drugs, what are your recommendations for how they find that data for their tribe, either using your tool or other ways?
Yeah, so this is where things get a little bit messy. So within our tool, we do have, at the top of the page, you'll see a button for all-cause overdose and opioid overdose. The default is all-cause overdose. This is what I explained earlier a little bit. The data, and it's just the way the death records are completed, the data are better and more reliable at the top level, so all-cause overdose. Once you get into subcodes, the type of substance that someone overdosed on, the data get a lot less reliable. So we have included the opioid data because for those places where the data has been reported well, we felt an obligation to report them back to communities. But that's the only other substance that we have really tagged. What we know in the national data is that about 65% of overdose mortality at this point is attributable to opioids. What that means is that when you're looking at other substances, the numbers start to get really, really small, and the number of counties that would be suppressed would grow tremendously. So we've not included those data at this point. We are starting to talk to USDA about ways to include data on other substances, but that's just going to be a lot harder and probably not as granular because we don't have as high a quality of data. So those data tend to come from surveys like the National Survey on Drug Use and Health, or from treatment data like the treatment episode data set. But those are not complete data sets of everyone who is potentially using a substance. So it just gets harder to drill down to the community level.
Great, thank you. Yeah, that's the frustrating part of this is it's hard to get that more specific data. I know some tribes are doing their own local data um, work to try to figure that out, but as I look at the map, I see some areas where I know the problem is more of a meth problem rather than an opioid problem. And I mean, you make a good point. You qualified it was a little harsh in a way, but if you don't die from the drug, it's not going to show up in these statistics. So, you know, a lot of people take meth, but they don't die as much, you know, but it's still a big problem that tribes have to deal with. So
that's right. And, you know, it's becoming more and more complex because a lot of the people who do die when they're using meth, we're finding more and more that meth has been laced with fentanyl. So it's being classified as an opioid death. So even within substances, as I was talking to a colleague in West Virginia, and he was talking about how now nobody's using a single substance. It's all drug cocktails, so that it's a little bit of this, a little bit of that, and trying to separate out what the cause of mortality is becomes a lot more complex.
Oh, wow, I didn't think of that, but you're right. Oh, my goodness. So those are certainly going to be challenges as we move forward, but I know we appreciate the efforts of your center to try to put together this tool and try to look at the tribal reservations and look at the American Indian Alaska Native data with the other overlays, because some data is better than none as long as people qualify sort of the strengths and limitations of it. And we really appreciate your sharing, willingness to share this tool with you. And I also really am grateful for the resources that you shared, the toolkits that you have available. I'm certain many of those will be very helpful to tribal communities as well. So we'll try to spread the word about that. We're getting close to the end of the hour. I just want to see if there's any more questions. You can write your questions in the question pane. I think we have time for one or two more questions. Feel free to write that question in the question pane. And we'll see if anybody has one last question before we end. I don't know, Michael, if you have any other comments. Here's one more question or comment. It says, an alcohol attributable death compete for some of the same folks. This varies greatly by state and region. Is it possible where alcohol deaths are very high, drug deaths are lower?
So we would need to dig into that a little bit more. So we did a study. This is not a national study. It is not a study looking at Native American populations, but we did a study in the Appalachian region where we looked at what are referred to as deaths of despair. People may be familiar with that terminology, but those are overdose deaths, suicide, and alcoholic-related liver disease. And what we found is that, at least in the Appalachian region, about 65% of I'm not stating that right. Overdose deaths were about 65% higher than in the rest of the nation. Alcoholic-related liver disease was about 10% higher than in the rest of the nation, but both of those were on the increase. And I think that's what's notable is these things the proportions may differ by community, but they tend to rise and decline together. And that's what we saw with all of those three causes of death. And I would suspect that's probably true in Native American communities as well. Alcohol may have a greater burden as compared to other causes, but they probably rise and fall together.
That's really interesting. Thank you for that. Well, I see we're almost to the top of the hour, and so I would first like to thank our speaker, Michael Meek, for his willingness to join us today. And we're so grateful that you could share this information. I'm sure it'll be helpful, and it was a really interesting discussion about it confirms the difficulties tribes have of finding accurate data on opioid and overdose deaths. And so if some of this data is helpful to them, then that will be a great progress will be made. So thank you so much. I'd also like to thank everybody else who joined us today on the webinar, and don't forget to complete the feedback form that you'll receive in the follow-up email after this webinar. And this webinar will be available as a recording soon on our YouTube channel that you can access from our website. And please feel free to send the link to the webinar recording to any of your colleagues who may be interested. And I have just a couple of announcements before we leave today. Watch for announcements about our webinar series. We try to do them monthly, and watch for announcements for the next topic on our website, on Twitter, or our listserv. If you're not on our listserv, email research@ncai.org and we can add you. We've also included our Twitter handle and website information on this slide. I also want to encourage you to visit our website. We have PowerPoint presentations from the Tribal Leader Scholar Forum last year. We also have several new publications on our publications page and a couple of new letters on our research recommendations page. And our website address is www.ncai.org/PRC. And save the date. I hope you all can join us for the NCAI Annual Convention and Marketplace in Albuquerque, New Mexico during October 20th through 25th, 2019. We have a great agenda that's now posted on the NCAI website, and we hope to see all of you there. Make sure you can attend, and you can find more information on the website, ncai.org. So again, thank you all so much for joining us today. We really appreciate your attendance and the great questions that were asked. And again, we also appreciate the speaker, Michael Meat, and the great tool that he was able to share with us today. Thank you all, and goodbye.